Hello, my name is Soledad Serazulo, and this is my clinical case presentation for the subject Applied Anatomy and Physiology. The patient LC is a 32 years old female archaeologist and treasure hunter. She is single, follows a vegan diet, and exercises daily. The anthropometrics are as follows. Height is 175 centimeters. The body weight is 53.6 kilograms. The BMI is 17.4, categorized as underweight. The usual body weight was 61 kilograms, and the ideal body weight is 65.6 kilograms. The history of present illness: LC started experiencing these symptoms 3 months ago: abdominal distension, poor appetite, nausea, worsening epigastric pain, new onset vomiting. These symptoms led to a significant weight loss of 12.13% or 7.4 kilograms in 3 months. 4 to 5 days prior the hospital admission, she started to develop headaches, cough, diarrhea, fever, night sweats, rash on her legs, and general malaise. During her hospital admission, LC developed hypotension and pulmonary edema. She was admitted to the intensive care unit, requiring mechanical ventilation, a nasogastric tube for decompression, and total parenteral nutrition. The primary diagnoses are hantavirus, which is a virus that causes pulmonary syndrome with symptoms such as fever, cough, fatigue, and shortness of breath. Valley fever is a fungal infection that shares symptoms with hantavirus and also includes a rash. Small bowel obstruction secondary to ascariasis, that is an infection caused by a parasitic roundworm. The secondary diagnosis is severe protein calorie malnutrition, hypotension, pulmonary edema, pressure ulcer stage 3 on coccyx, and disseminated intravascular coagulation. LC has experienced the following procedures: abdominal X-ray show air-filled tubular structures. Abdominal ultrasound reveal non-peristaltic small bowel. CT scan identify tube-like structures, small bowel obstruction, and ascariasis with ischemia. Laparotomy reveal proximal necrosis of the jejunum, a vessel mass, and perforation in the duodenum. The surgery involved a duodenectomy, total removal of the duodenum, and resection of 100 centimeters of the proximal portion of the jejunum, creating an end-to-end anastomosis. The PES statement includes severe protein caloric malnutrition as related to a small bowel obstruction, jejunum ischemia with necrosis, vessel mass in the duodenum, vegan diet, and lack of nutritional education, as evidenced by BMI 17.4, categorized as underweight, significant weight loss of 12.13% in 3 months, low albumin levels, and low vitamin D levels. Other statement is vitamin B12 deficiency as related to the adoption of a vegan diet, and malabsorption due to the ileal resection, as evidenced by serum vitamin B12 levels, low red blood cells, hematocrit, and hemoglobin level. 4 days after the surgery, the ileus was resolved and the LC began enteral nutrition. The parenteral product selected is Vital Peptide 1.5. Is suitable for patients with malabsorption, maldigestion, and other gastrointestinal conditions. Additionally, it's a high caloric density, which is favorable for the patient who has a severe caloric malnutrition. The recommendations are energy requirements. It's 1,700 kilocalories daily. The protein requirements is 80.4 grams protein a day, and fluids needs are 2,000 milliliters daily. The recommendation is to administer 5 bottles or 1,185 milliliters of Vital Peptide 1.5 daily through continuous feeding over 24 hours at the rate of 49.4 milliliters per hour. The total calories I will provide through the tube feeding to LC are 1,777 kilocalories daily. The total calories provided exceed the recommendations, but considering the patient has caloric malnutrition, is not significant for her. 80.4 grams of protein will be delivered daily over 24 hours, which equates to approximately 3.35 grams of protein per hour. The fluid recommendation is 2,000 milliliters daily, with 1,185 milliliters coming from the enteral formula and 850 milliliters administered by flashes every 4 hours, consisting of 135 milliliters each. The nutritional implication of the diagnosis and procedures regarding to the end-to-end anastomosis, the functional absorption capacity is decreased due to the resection. Considering LC follows a vegan diet, it's essential to monitor her nutritional status periodically after discharge. The resection of the duodenum makes nutrients such as iron, calcium, and magnesium critical. Jejunum resection promotes reduced nutrient absorption, flooding of lower bowel with fluids, and reduced absorption of calcium and drugs. Previous ileum resection includes reduced nutrient absorption, reduced sodium and water transport, reduced or absent vitamin 12 absorption, choleretic diarrhea, and fat malabsorption. The nutrition objectives post-surgery and pre-transplant are restoration of nutritional deficiencies, maintenance of an appropriate weight, consume an adequate amount of proteins, achieving an adequate nutritional status at the time of transplantation to help prevent infection and promote wound healing. The discharge recommendations are accompany iron-rich foods such as legumes and with vitamin C. LC can add lemon juice to the meal or have for dessert a citric fruit. Calcium competes with iron absorption. However, in vegan patients, there is a physiological adaptation for absorption of both. Have a low intake of insoluble fiber and residue. It's recommended to peel fruit and vegetables, removing seeds. The protein sources are beans, grains, nuts and seeds, green leaves, soy, quinoa, buckwheat, and amaranth. Vitamin B12 supplementation is fundamental. Sun exposure to promote vitamin D synthesis. Fruits and vegetables well sanitizing. Drink potable water and bring a water if LC will be outside for a long time or doing sports. Periodic lab tests are necessary to check for any deficiencies. These are my references, and thank you and have a good night.